Good morning, everybody. We'd like to welcome all of our friends from the East Coast, the West Coast, and around the world to another excellent session of the ASMBS Fellow Project. We are really excited for today's lectures on access to care. Just a couple quick housekeeping notes. The national meeting is coming up in Las Vegas at the end of June. We encourage you to register if you haven't already, and we look forward to seeing you if you have. Also, don't forget to register for our next bariatric surgery training committee happy hour. So we do a monthly meeting on the fourth Thursday. The next one will be June 22nd. And we do alternating journal club and video review. So please join us for that. We will move on to today's lectures. So we have two amazing speakers today, Dr. Renee Hilton-Rowe and Dr. Joe Northup. They're going to be talking to us about access to care, what the issues are, what the scope of the problem is, and how we can all help. We are going to begin with Dr. Renee Hilton-Rowe, who is an associate professor at the Medical College of Georgia at Augusta University Medical Center. She's the section chief of minimally invasive surgery and the director of the Center of Obesity and Metabolism in at Augusta University. She is the past ASMBS State Access to Care representative for the state of Georgia and is currently serving as the president of the Georgia ASMBS state chapter. She is the Access to Care Committee co-chair for ASMBS and serves on numerous other committees within ASMBS. She currently resides and practices in Augusta, Georgia, and enjoys spending time with her family, hiking, skiing, boating, traveling, and pretty much any activity that involves the outdoors. She is going on vacation today, and I cannot thank her enough for joining us. That is true dedication. So thank you, Renee. Our second speaker will be Dr. Joe Northup. Dr. Northup did his residency at the Medical College of Ohio and then did his fellowship at the University of Virginia, where he stayed on as faculty for five years, followed by a stint in Cincinnati, Ohio. Dr. Northup actually started a bariatric program at Mercy Health and now currently is in Chicago at BMI Surgery. He is a CPT code representative to the AMA, which is a thankless task, and we thank him for doing it so much, and is also on the executive council of the ASMBS. Dr. Northup, thank you for joining us, and we will have Dr. Rowe take it away.
All right, so thank you for that warm welcome. From Dr. Jain-Spangler and Dr. Eckhouse, it's great to be here. And yes, this talk is all that stands between me and St. George's Island. So I'm going to give it and then get to some sun. So my talk today is going to be basically on the terminology and kind of what is access to care. I wanted to define some terms for you guys because not everyone is familiar with the jargon, so to speak. We'll discuss the scope of the problem, what access problems do we have in America, and then also we'll review some current literature to focus on one specific patient population that Dr. Jain-Spangler asked me to focus on, which is our minority population. I give a lot of DEI talks regarding access as well. So we'll specifically focus on race and sexual gender minorities and barriers for these patients. So some terminology to define. I think the two most terms that I hear used interchangeably the most, and they're different, are access and utilization. Access is having insurance. It's defined as the right to obtain or make use of or take advantage of something as services or membership. Utilization is using that insurance. That is the action of making practical and effective use of something, is how utilization is defined. So we hear a lot of times people saying, man, we have an access problem for this group of people. If that group of people has insurance, there may be still some areas that are gray where we may call them access, but most of the time this is a utilization problem. And I know that both Dr. Northup and myself feel very passionate about utilization being a big target for the next 2 years. Some more terminology that you'll hear as you go into practice next year that's going to be very frustrating for you. One and done. We're seeing a lot of this fade out, but this is an access to care term for when an insurance provider specifies you get one operation treatment ever for obesity, and then you're done. So if you've had a sleeve and you come back a year later with, the worst reflux ever, some weight, regain, they're going to say, nope, you got a sleeve. You can't ever have a bypass. And that's really frustrating. We're trying to make sure we get rid of all of those. Policy exclusions to me are even more frustrating. This is where medical services are not covered by an individual's insurance policy with no exceptions. Even if they have a BMI of 60 with diabetes and a hiatal hernia, the insurance company may pay for you to fix that hiatal hernia, but not for you to do the bypass. And that can get really frustrating when you know the better option for this patient is just one that they specifically have an exclusion for. And it's really frustrating when you read some of these policies, because sometimes bariatric surgery will be listed right next to plastic surgery under policy exclusions. And we know that what we do is not cosmetic. And then expenses not covered. This one gets even more tricky, because sometimes bariatric surgery will be set apart from the rest of the patient's insurance and they'll have a higher deductible, or they'll say, your pre-treatment approval is necessary, but we're not going to pay for it. We're not going to pay for your psych fee, or we'll let you have these procedures, but you're only allowed to have a vertical banded gastroplasty or a bypass, which is really outdated, as we know. But again, these are less commonly seen, but still out there. I also kind of wanted to just make a list of who I call the players. If you guys are interested in access after this talk, ASMBS is honestly, I think, the best place to start. We have an access to care committee. We have an insurance committee, our state chapters committee, all three of these committees with the guidance from the executive council. Access is always a big focus. You have the obesity care continuum, or the OCC. You have OCAN, OAC, and then the obesity pack is another one that I would definitely encourage all of you to join as attendings. They offer great things. There's grant money for state chapters to lobby. So if you go somewhere next year that has poor coverage, you can actually apply. It's a super easy grant to apply for. It's like one page, not like a research grant. And they gave us money in Georgia to go to the state capitol. It's really easy, and I think super important. So what role does insurance play? I've already talked about the fact that if you don't have insurance, clearly that is a huge hurdle. That's a major access issue. And I'm going to show some heat maps in a second to show you which plans are still not offering bariatric surgery. But even in the case where patients have insurance, insurance still can play a barrier. So even if you have insurance, it's up to people to get to us, right? And this is where that second term utilization comes in, which ultimately ends up probably being the biggest access blocker for many patients, is they don't actually make it to our office, even though they have a policy that would cover it. And when you look at national surveys of primary care providers, 53% believe that most of their patients could not afford the surgery. So either the primary care doctors believe this, and it may not be true, so they don't send them from a cost standpoint, or the patient cost sharing has been so high on certain policies that that's also been identified as a barrier. So it's kind of hard to write these financial papers. I think they're way harder to write sometimes than basic science or even patient outcomes. But the three papers at the bottom are all papers written within the past kind of 5, 6, 7 years. They're great papers looking at economic value and insurance issues. So if you want some light reading, these are great. Here are the heat maps. So that's another term you've probably never heard. Heat maps are basically our maps where we map out who's got coverage for what based off the policy. These are from 2020. They have not been updated since then, but we're very close to getting updates. So stay tuned. If you go to the ASMBS website, all of these things are available under our Access to Care Toolkit. So this is state Medicaid. And as you can see, state Medicaid, we actually have great coverage. And this is one of those insurances where I hear a lot of times from my primary providers, I'd refer them to you, but they have Medicaid. I know it's not going to be covered. And I'm actually like, yes, it's actually, they probably have the best coverage. They only have a very, very small out-of-pocket expense in Georgia. So don't let people not refer you patients because they're going to assume that they don't have coverage with Medicaid. Most Medicaid policies cover us. This is the adolescent Medicaid. And what you see is a lot of unspecified. Again, when these maps get updated, I hope we really focus some on the adolescent ones because I know in Georgia it's covered. This is a slide that's near and dear to my heart. This is really where I got involved in access, was through state employee coverage. When I first moved to Georgia, we didn't have it. And through a lot of advocacy efforts, Georgia got it. So just over the past 5 years, Wisconsin turned green, Georgia, Louisiana, Montana turned green. We only have 3 states left, and that's Idaho, Utah, and South Carolina. So those are always targets and focus for our committee. Again, the adolescent maps are always, there's a lot of gray. And what you'll find that some of these policies actually say is it'll be on like a case-by-case basis. So they may have coverage. You just may have to do a peer review, talk to the medical director to get the adolescents in. And this is the Essential Health Benefits Plan, which is basically Obamacare, the Affordable Care Act. And I was shocked. I had not looked at these heat maps in a while, and I thought we were doing much better than this now, but this clearly is going to be a target over the next 2 years for me as I take over the Access to Care Committee. So access or utilization, tomato, tomato, I don't really care what you call it. We have a big problem. We are currently only have 1 to 1.5% of patients eligible to have bariatric surgery using the benefit. So whether it's because they have an access issue getting to the provider because their PCPs aren't referring them, discussing surgical options, whatever it is, or maybe the resistance is within the patient or they're hearing from their family members, it's not safe. I think that utilization and getting the word out has to be a big focus. And again, 2 other great papers on the screen down there if you want to read more about this later. So just a little bit to arm you with a little bit of data. If you have an access talk in the near future with one of these PCPs or insurance companies, from a money standpoint, I feel like we are constantly targeted the only specialty that's having to defend our honor, so to speak, and show that we're cost effective. But they typically recover their cost in 2 to 4 years, depending on the type of surgery. And honestly, I think with diabetics, it's probably closer to 1 year. 25% of your patients considering bariatric surgery are going to get denied insurance coverage 3 times before getting an approval. So next year, when you're out in practice, don't give up. Do the denial, do the peer review denials, and do it over and over and over again until you start to make progress. And the reason that it's important to get these patients through the program once they start is about 60% of our patients report their health worsened during this period. That we know that this 6-month weight loss program and period, they don't help. They don't lead to greater weight loss. It actually just worsens outcomes. And the next population that I specifically wanted to talk about is our access problem for minority patients. And yes, we have access and utilization problems that are much bigger in this patient population, and it spans all ages, adolescent, adult, and geriatric. This is the 5-year analysis paper that just came out recently from Ben Clapp and Omar Ghanem. And basically, you can see the race distribution. This is all of MSQIP over the past 5 years. And clearly we have much better utilization in white population, 71% of our patients. When you look at Black or African American, that drops to 17.8%, drops again to 13.4% Hispanic. And then when you get down into other and Asian populations, we're less than 1%. So why are these patient populations not making it to surgery? This is a really good paper that focused specifically on this adolescent population. And it said, well, what if we make the access better? What if we give them all government payers? Medicaid insurance actually further decreased the use of metabolic surgery in non-white adolescents. It increased it for whites. So maybe just an expansion of a government-sponsored insurance alone is unlikely to eliminate the race-based disparity. Even when Black and Hispanic adolescents go through the program, they're less likely than white counterparts to receive authorization. And they're also less likely to see their doctors appeal it. So again, we have to do better advocating for these patient populations. In African American men and adults, there's 11% eligible, but again, they're only 2.4% of that 17% that I showed you on the first slide talking about racial patient use. And that's despite being eligible, both based on BMI and obesity-related comorbidities. When African American men receive surgery, they're significantly younger, but have greater comorbidities and have worse outcomes when compared to white men and all women, including Black women. So looking specifically, the next 2 slides are going to look at Texas and Florida. And it looked at the Hispanic population, which you would assume would have greater access in these states, given that they have a greater population of Hispanic patients. They actually had the lowest rate of utilization. Even when they adjusted for everything else, Hispanics still had the lowest rate of utilization in Texas. And what they found in Florida, this was Dr. Crystal Johnson-Mann's paper, is that they were less likely to even be referred. And they thought that a lot of this might be explained by the disproportionate number of self-pay Hispanic patients. What I tell providers is, just refer patients to me. Don't even look at their insurance. Even if it says self-pay, refer them to me. Sometimes someone that's self-pay, they have other options and we can help them investigate those. This is looking at Asian access or utilization, especially with our new guidelines, lowering the BMI cutoffs. Again, you saw on that first slide, we only have like 0.52% of our patients are Asian. And when we look at their outcomes, they actually have better outcomes, or at least the same as white patients. a couple of areas such as wound disruption and complications, deep SSI were actually improved. But when you look at length in the program, we see racial disparities even in this Asian population. White patients, when you remove all other barriers, when they have insurance and get into the program, white patients make it through faster than all of these other racial groups. This is looking at the geriatric population. While bariatric surgery was equally safe, mortality rate the same in Black and white patients, morbidity was higher in Black patients. When you account for all confounding factors, take everything else, make it equal, just the access, Black patients were tenfold less likely to receive surgery than white patients. So clearly, this is a little bit more than an access problem, right? I'm making that clear. I love this study because it's out of Canada. They have one, socialized healthcare system, or everyone's got the same payer, so it should be equal, right? But it's not. And these would suggest that even with equal insurance, you still see these disparities. I like this survey because what it shows is that when you survey patients and you determine their interest, what's going to get them into your office, white and Black patients feel very differently. White patients are more likely to have surgery if they've seen favorable stories, blogs, know someone that had surgery, whereas Black patients' interests are greatly influenced by their primary care physicians talking to them and by being told about additional health benefits. So when we identify some of these barriers, the insurance and utilization being a big one, cost, if they have insurance, but their copays are huge or their hidden fees, that can be a great, deterrent. Distrust in the medical system. Stories like Henrietta Lacks and the Tuskegee experiment were not that long ago. So there is some distrust in certain racial minority communities with the healthcare system of having elective operations. I think education is a big, big area of focus, making people understand that this is to treat diabetes as much as it is about their weight. And then lastly, society's expectations. I'm a huge Georgia Bulldog fan, go Dogs, but our offensive line has an average weight of 330 pounds. We expect these young men to be big and carry this burden, but the fact is, when you look at retired NFL players, there's a whole separate, obesity problem that we need to address. Lastly, I want to talk about sexual and gender minorities. I stole this term from Dr. Nova Suzoka after an AIS lecture I saw her give a few months ago. And it made it a little bit more simple for me to kind of break groups into two separate groups. Which was gender minorities versus sexual minorities. Makes it a little bit easier, I think, to educate, which I think is probably the biggest area of focus for this group. Is again, there's such a limited knowledge and education for healthcare providers that leads to distrust, fear, even refusal to treat, and outright, horrible cases. And when you look at what the research suggests, is that if you integrate education into and inclusive policies into the healthcare system, whether it be from undergrad all the way up to our medical societies, there is improvement in acceptance and possibly an increase in access. The last term I'm going to define today is intersectionality. If you polled this audience, half of us probably don't even know what that term means. But what it means is that all of these categorizations are interconnected rather than being separate entities. It's not as simple as fitting someone into a bucket. Not everyone is a square or a circle. If you are a Black transgender male, you may not identify as just one of those things. And it's not as simple as just adding them up. There's really a synergistic effect. And I truly do not think we understand how this affects our patients. This is from the previous paper. It's a great paper. I encourage you all to read it. I think that we even have to throw obesity into the box of intersectionality because our patients are experiencing bias just purely off the fact that they have obesity. So that even further complicates it with our patients. And I think we need more data. So with that, I'm going to end with access in a perfect world would be if every single insurance company provided access to every single patient based off of our new 2022 guidelines, which I encourage all of you to read and review. I love this slide because it shows the difference between the ones that we've been using for the past 30 years, the 2022 versus 1991. And this is obviously a big fight in the access world right now for us, trying to get everyone on board with these new guidelines. So with that, I'm going to turn it over to my dear friend, Dr. Joe Northup, who's been a great mentor and access to me and has led the committee and championed this fight for many years. And I'm excited to see what we can do together over the next two.
Well, thank you so much for having me here this morning. I think that was a fantastic lecture from Renee, and I, of course, let her do all the heavy lifting. So a lot of this will be a little bit repetitive. But I will go through this briefly. I'd like to generate some more options for discussion and maybe some questions, and honestly, some places where you going out into practice as fellows can have an impact on our future. A lot of times, access to care is as Dr. Hilton can tell you, is a thankless task and a lot of heavy work for that's kind of behind the scenes, and no one realizes how important it is or how much value is there. But it really is important to participate, and if you want things to change, you have to make time to do that and participate in not only your patient care but their overall management and getting them the ability to have surgery. So my disclosures are important today. So we talked about the cost of obesity. You guys have seen this slide, I'm sure. This is a great slide to use. I pull a lot of this data from the Obesity Action Coalition, OAC. This is a fantastic resource. I can't express Joe Naglowski and the work he does. This is a patient advocacy group that generates attention to access disparities, challenging burdens patients face, overcoming obstacles to access to care. But they pull this data, they have it for each individual state. So when you go to talk to representatives or make some, headway in obtaining access to care, tremendous resources here. But looking at, what we currently spend over $2 trillion, how much healthcare costs. And again, this is broken down and ranks every state. So it's important locally where you are. I know Renee kind of looked through all these heat maps. I won't go through all these again, but I want to make a quick example about state employee coverage. This, again, as Renee said, we're waiting for the new update on these. But in the last, 2 years, we have moved the needle on Louisiana, Georgia, and South Carolina. Now they all have state employee coverage. So these have really changed. And, I'll talk about some opportunities for access in a moment, but it's important to know that this has changed over the last, 10 years, how we've moved and changed and added employee coverage and added coverage for Medicaid. And we really made a difference doing this. And this comes down, honestly, to a handful of people that work on these projects and motivate others to, take time and make people listen and make these decisions. And a lot of times it's not, a combative, scenario where you're having to fight to get these things done. It's just an education process and bringing attention to some of these issues and the importance of obesity care and weight management. But we have, again, moved South Carolina, Georgia, and Louisiana. I know she went through these, so I'll just go through them very quickly. But so one thing I want to make clear too, when we talk about bariatric coverage, coverage doesn't mean coverage. What we see is, especially, for example, Louisiana, it's the coverage there's, we have state employee coverage. You can we can paint the state red and on our heat map. However, it doesn't mean we have good coverage and actual, true access. A lot of this people have coverage where we have, they still have a 6-month diet. We really worked hard to get rid of a lot of those. There'll be requirements where patients can't gain weight during the workout process, or they can't lose weight during the process. And there's no data to support doing that. Renee already mentioned once per lifetime surgeries. This isn't as common as it used to be. This is becoming, we'll talk about revision surgery in a minute. So it's kind of everything kind of, flips back around as we'll see. To have disproportionate copays. A lot of people have coverage, but they'll have $8,000 and $10,000 copays, and they'll have different copays based upon bariatric surgery versus hernia surgery or hysterectomy. They will have a different level of financial responsibility, which is completely inappropriate. Again, extreme workup and documentation. We're dealing right now with California, Blue Shield of California. They just implemented, we'll talk about the new criteria Renee mentioned, but they're implementing new criteria really following that. However, they added a 1-year medication weight loss requirement prior to surgery. They want their patients to be on 1 year of medication before they'll approve surgery. So that's, completely nonsense. There's no data to support doing that. Even the FDA recommends, stopping medication 3 months after utilization if there's no significant weight loss. So, but these are the kind of hurdles that when, it's always it's 2 steps forward, 1 step back. But we see even when we make these positive changes, a lot of barriers put in place. To talk about more about access to care, one of the big areas we've been working on even before the ASMBS, and if so, released new criteria, is looking at low BMI and type 2 diabetes. In the last 12 to 18 months, we've had significant improvements. Most of these are regional plans. We're just now starting to get the national plans to move over where they are covering low BMI and type 2 diabetes. We are seeing a lot of requirements for hemoglobin A1C documentation of less than 7 or 8. So, and this is something that just came up again. I always like to say that the Access to Care team, we are the complaint box of ASMBS. When someone has a problem or an issue, we are often the first people to get an email. Emails come through various, sources of entry into the ASMBS for complaints, and a lot of them end up in the Access to Care team's inbox. But I just got an email about requiring hemoglobin A1C control prior to surgery. And this is I've not seen this be a barrier, true barrier. You'll see this on the requirements, but basically it wants your patients to be compliant with their medical care. And that's not an unreasonable ask. I think, we have to always not fight every single thing and realize that some things are not unreasonable. And even if the patient can be controlled, if you document they're compliant with medication and get a letter from the endocrinologist or the primary physician, this is not really a true barrier. And you almost always get these patients approved. But again, as I said, we have made significant impact, and this is again, this is updating so fast with the new criteria that we can't keep up with this. But in the last 18 months, we have added over 3 million covered lives, and I want to say it's up to 7 or 8 million now with the newer insurances coming through, where we have added this care. So we are making progress in better expansion of coverage. Again, dealing with some of the barriers that we have, but you can see this is a list of all the regional plans. We're now starting to see some national players come in and more regional plans for up to almost 7 or 8 million covered lives now. We expect that to continue to expand and expand. So progress with the Anthem. There we go. So again, in the recent past, Anthem always had 6-month diets, and this is something I think our access team really worked hard on to eliminate these. So we are able to, meet with Anthem. You have to meet with them multiple times, talk to medical directors. Finally had a national meeting where they agreed from a national coverage decision to remove all 6-month diets, preoperative diets from their insurance plans. However, one of the things that's interesting that in Access to Care, you'll see that there's a very strange situation where the regional medical directors can override the national coverage decision. This is even true with CMS and Medicare, that the local directors have I'll say more power, but they can ignore or go around or modify national coverage decisions. So we still have 6-month diets, even with Anthem, even though their national decision is no longer to have it. So, so this has mostly gone away for the most part, but it's still there. Some things that are interesting, you'll see how things work, is they will offer, all of our plans are offered without 6-month diets, but they, insurance is, health insurance is sold like life insurance, right? It's not bought, it's sold kind of thing where you have to, go in and sell it to people. So they will go into businesses and let's say, okay, we will cover all your employees for this amount of money. If you want to add bariatric surgery coverage, it's X dollars plus a percentage higher. And then they will say, well, if you want bariatric surgery coverage, we can offer it to you cheaper, but you can add a 6-month diet and we'll give it to you cheaper. Again, in the business, they just look at it as a business expense. So 6-month diet or not doesn't make any difference to the person making this decision, but they will look at this as a way to save money. So again, 6-month diets get quote unquote requested by the business they're selling it to, but that's done to save money. But Anthem covers over 30 million lives. That's a big insurance player. So we've made a great amount of progress with that. There we go. Aetna, same thing. They've always had a 3-month and 6-month diets. This is where, we'll talk about advocacy in a minute, but really patient advocacy moved this along. The Obesity Action Coalition, Joe Naglowski and the OAC really made a great impact on Aetna, and we removed all their 3- and 6-month diets. And they moved to a 12-month visit process before surgery. And you may not see this as much now as fellows, but you will start seeing this more and become more important to you as you move into practice, how you move patients through the process. And, what changes between, fellowship and practice is a lot of this kind of stuff. This is the stuff that, makes your practice work, makes things, how do you get through patients? And it's important to help patients do this because it's a lot for them to figure this out and understand this. But what they've changed to a policy of 12 documented visits that they have to come in before surgery. So I remember vividly, I was on the, I had pushed Aetna to help work on this, and I was on the call with the senior medical director for the National Aetna Business Division. And they were talking about moving to this. And my first thought, honestly, was this was going to be a 12-month visit. They're going to come in once a month for 12 months, and it's going to take a year for everyone to get surgery. And he assured me and promised me that you can do 12 visits in 12 days and they would approve surgery. And to be honest, they have been very agreeable to these visits. They have, most people are doing it in 12 days, but it usually takes a couple months, which is pretty reasonable in this process. But they're doing psych evaluations, any office visit, they're exercise physiologists. I even had a coordinator. We have a lot of allied health members that work with us, which you will find how important those people become more and more important throughout your career to help you and manage your patients and get people through this process. But one of them came up with the idea of using the intake seminar as one of the visits, and they count that as well. So it's been a very positive response. And so we're getting the patients through much faster than the 3 to 6 month, mandatory requirement. UHC and Cigna, we dropped their 12-month and 6-month criteria. Again, same kind of process, just going through and educating and holding them to the data. And so we've got great access. Again, not 100%. There are still programs out there that still require 6-month diets. United Healthcare, the Optum Center of Distinction. This is always a challenging one. Many people have trouble getting access. My current practice, we do not have an Optum Center of Distinction just because of the criteria that it's just impossible to go through. One of the things that they put in their center, we just had a meeting with them, 4 months ago, Dr. LeMasters and myself, trying to have them update to the new criteria. And they still have a process now where centers performing greater than 5% adjustable bands, they're eliminated as an accredited center, which is, again, it's a very challenging hurdle that we see. But very few centers are doing bands. I'm sure, many fellows coming out now probably never done a band. Maybe you've taken some out, maybe you've managed them or not. I think it's going to be interesting to see, as time goes on, how much is it going to be challenging for us to not have the education around managing bands. But again, there are still people performing bands. This is a recognized procedure by the ASMBS. And at the end of the day, I think this should be my decision, my patient's decision, whether we do or don't do bands. I haven't done bands in many years, just as my own choice. But, I think that should be the patient's choice and the surgeon's choice. And then what happens is people flock to the center. The very handful of centers are still performing bands if that's what they want. And again, just having a higher volume of bands, because that's where they're being performed at, they're losing their center of excellence where they can't do any type of bariatric surgery under their insurance. So again, that's something we've tried to eliminate, but they're pretty much sticking to their guns. And this comes back to the discussion point about revisional surgery, which we'll mention here in a second. Blue Cross Blue Shield. This has been another area of contention. As you get out in practice, you will start going through the process for the MBS AQUIT program for the American College of Surgeons. And, this is a fantastic data collection process done by the American College of Surgeons, where all of our data is put in. I don't know if you guys get an opportunity to see this. You should all go and ask for the semi-annual report, the SAR data, and take a look at that. And have your surgeon or your coordinator is probably a better person, or your data entry person, your MBS to go over this data with you and show you what's on this and why it matters. It basically tracks and compares all your complications, readmissions, reoperations, bleeding, all these, all the numerous different criteria. So Blue Cross Blue Shield a year ago decided they tried it several years ago on wound infections, but then they dropped that, and then they have now going to using one of the data points as a lower confidence interval. And they arbitrarily decided that this must be less than 1 for 5 different criteria for every surgery. And if your number's over this, you will automatically lose your accreditation. And when and we're guilty of our own success when again, it's very much worth your time to go through your semi-annual report and look at this. And when you get down to where our complications right now as a society are pretty low. I mean, mortalities have dropped substantially, leaks have dropped substantially, even leak management has changed to where it's much more tolerable for patients. Wound infections are low. So when you get to that low numbers, you're doing 300-400 cases a year in high risk BMI, higher BMI patients. You get a extra wound infection or two, you are changing your data. And it's a data collection issue, but so 1 or 2 small wound infections, or 1 leak, or 1 mortality, or 1 pulmonary embolism can make a huge difference in your data. And we're seeing people lose their blue distinction center and the ability to do surgery based on some arbitrary number they decided. And in one of the communications I've had, again, Renee and I have been doing this for a long time. I've been doing this a few more years than Renee. And in one of the meetings we had with a medical director, their targeted goal was to eliminate upwards of 50% of the centers in the United States in the next 5 years. Again, talk about limiting access to care. If there's no center, like I think it's, Renee probably knows better. I think Alabama has no blue distinction centers in the entire state. It's Alabama or Mississippi. I can't remember. Maybe it's Mississippi. There's not one blue distinction center. The most common insurance in the state is Blue Cross Blue Shield, and there's not one center in that state that can have bariatric surgery performed. So again, there's different ways. There's not just patient criteria. They have their own ways to manipulate access. So revision bariatric surgery. So if you look at our numbers, and I'm sure you guys are seeing this as fellows, as the type of your case mix is changing a little bit. So this is the area that's growing the most, for good or for bad, is revision bariatric surgery when you look at our numbers. So this is becoming an insurance target. What this really started from was a lot of the band issues. The reason we don't do bands anymore is because they weren't as successful as other surgeries have been. They're not, I'm not making a comment on how bad or good they are. They're still reasonable to be performed, but the success rate wasn't as good. And what happened was we put in so many bands years ago, and now we're revising them to other surgeries, taking them out. So the insurance, they want one surgery they want one and done surgeries. As Renee mentioned, there's a reason that's in there. They want this surgery to work and be done, and that's it. And so when we're going back and revising surgeries, and especially we're looking at sleeves right now, revising a significant percentage of our sleeves, that's certainly my most common revision operation has changed from band to something to, sleeve to bypass. That's the most common thing, either for reflux or weight recurrence. Sleeve to other, metabolic surgeries are becoming more common. So this is a huge target for the insurance right now. They are going to really stop covering revision surgeries. There's actually already been criteria that, this flies around through our access group, but reflux for many insurance companies now is no longer going to be a criteria for, sleeve to conversion to Roux-en-Y gastric bypass. That's been taken off the table as an option. So they're just going to say, medical management, and that's it. So again, these are always fights we have to have. One of the insurance companies, CareSource, which is a type of Medicaid in a handful of states, they just updated their policy about a year ago to put criteria in that enlarged or dilated pouch is no longer an indication for bariatric surgery. So going in, trying to revise a large gastric bypass pouch or a large sleeve pouch to convert it to something else, they're not going to allow that to be an indication. So again, they're making this is the first of many kind of targets where they're looking specifically at revision surgeries to try to block our ability to manage our patients. So future for access to care, we still have a long way to go. We have to deal with, the CMS with they're always trying to reduce our payment. The move to outpatient surgeries is a big thing right now. That's a whole other topic we can talk about if we want to talk about, changing to outpatient designation. Decreased access centers. And, Renee did a great talk on this, and she and I talk about this all the time, is our utilization. We have many patients that have access to care, and we need to not only look at getting patients to have access, but when they have that access, to utilize that. So this is where advocacy starts, it has to start locally. And going out and talking to your primary care physicians, do a grand rounds, they'll have every hospital, even non-academic centers have usually a internal medicine group or a family practice group or, OBGYN or cardiology, and they will often have time for a guest speaker, offer to go in and talk about access to care and when to refer patients and how to refer patients. Renee really talked about how to do this, but take time to do that. And, and when we talk about, everyone wants to talk about the heat maps, changing those, most recently, Louisiana, Georgia, and South Carolina, this all comes down to one or two people. Dr. Hilton was instrumental and pivotal in getting Georgia to have access to care for the state employees. I mean, she worked so hard on that. She motivated so many people, and, she's become an access to care leader starting in her home state. And she, led the charge and made that difference. So one person does make a difference. One patient can make a difference. One surgeon can make a difference. So take the time to do that, and don't, a lot of people get frustrated and say, oh gosh, well, that person can't have surgery, and they get mad about it and just say, well, that's frustrating, sorry, you can have surgery. But if you take a time to make a difference, you can see how one person makes a difference. And, again, Dr. Hilton's been a fantastic access to care leader, and certainly has surpassed anything I've ever done. And, that state flipped over just because of her. So the updated criteria, I'm sure you've seen this, but this is what we're really pushing now. And we're having multiple meetings. I mean, it's almost on every other week, we're having a conference call meeting with insurance medical directors, trying to get them to adapt this policy. Again, they're very afraid of this floodgate that's going to open up, that all these new patients are going to come in. We're really not seeing that. And that's not much of a risk, but that's their concern. They look at it as, increasing access to care is increasing expenditures for them. They don't look at it as saving money in the long term, and which it does. But they look at it as just more surgeries going out. So I won't go through this. I'm sure you've seen this criteria, but this is something you need to know. This is something that we really need to advocate for, and really push referring physicians to rethink how they refer patients. So this is the last thing I'll talk about. How I mentioned how important advocacy is. Don't take no for an answer. Some of our access stars right now are some of the youngest people in our committee, and they're becoming the heroes of access to care just because they have a passion about it. Don't accept, they're not covered, you can't have surgery. Don't accept that. So work with your employers. As I said, employers have honestly no idea. Their insurance broker comes in, especially a small business. The insurance broker comes in, talks about their options. And most of the people that have a small business are the owner and the HR manager and the benefits director. And they'll say, just give me the cheapest thing that has the 10 essential health benefits. And this is not even a thought to them. So I think that's a great opportunity for us as we go through in the future. Take meetings with your insurance medical directors. Don't just let a bad policy exist. So motivate patients. As important as our voices are, their voices are even more important. If you can motivate a patient or bring a patient with you to a meeting, that speaks more powerfully than what we do. We look self-surveying. We look, we're trying to get more cases. The patients have such a voice, and such a strong voice, if you can motivate someone in your practice to do that. So there's always one thing as I say, is take one day. If you take one day out of your practice, shut your office down on a Wednesday or a Thursday, don't see patients, and take one day a year and do some advocacy work. Schedule meetings with your medical director, schedule meetings with an insurance plan, take patients to meet legislators. If anybody's interested, we have opportunities to go to DC and do Hill visits with your national leaders and politicians. If you have an interest in doing this work, but take one day for your patients and one day for your practice, and do some advocacy work. It'll really take some time, and really it'll be a minimal amount of time. It won't impact your life, but it can make a huge difference long term. So there's my email. I'm happy to always answer questions that you have, and I'm greatly appreciative of you having us today, and hope this was useful for you.
Thank you to both of our speakers. I just wanted to say I thought those were fantastic talks, and I really thank you both for being here. Shaina, take it away.
So again, thank you guys. Those were inspiring and truly inspiring. I have screenshotted probably every other slide throughout the entire morning. So thank you for fuel. Taking the one day at a time. One of my favorite phrases is Ruth Bader Ginsburg, right? Real change, meaningful change happens one step at a time. And you guys have shown how one person, one step can make a huge difference for our entire society and our patients that we're taking care of. So thank you for that hard work. There was a question, and I think you guys, I know Dr. Hilton-Rowe, you had already answered it in the chat, but there was a question of, is bariatric surgery indicated for a BMI of under 35? Dr. Northup, you mentioned that in your last couple of slides as well. I guess maybe since it's, yes, we feel it's indicated, there's a lot of good data there. How do we start to navigate, implement in our own state, in our local home, to your point, getting access for our patients when their BMI is under 35?
Yeah. So this is one of the hardest sells I think we have for patients. We have a lot of patients, and I know I see in my practice that their BMI is 45, and still sometimes they're reluctant to have surgery. So, this is where when I meet with the insurance companies, I say, look, we're not going to see a floodgate with this, because this is a hard sell to patients with BMI 32. And I think what we need to, again, switch the conversation from, again, the weight loss surgery to metabolic surgery, and the impact on this group will be in their metabolic disease, especially type 2 diabetes. And I think that's where we need to approach this. I think it's going to be more, especially in this current environment with better medications that we have, harder to get patients to choose this. The thing I think to focus on, again, talking to, your patient groups or anything that is that type 2 diabetes goal, but this is going to be one where the primary care physician is really going to have to make a difference. I think going out and discussing updated criteria and the data behind putting type 2 diabetes in remission. That's by far the biggest impact you're going to have. And I think every panelists, and Renee, you can talk to this, but I think physician referrals are probably certainly less than 10%, but probably closer to 5% of your business. Really, most of it is patient driven and patients come in. However, you look at especially with the data, a physician referral from a primary physician is far more powerful. If someone goes to your website and looks around and kind of does some kind of kick the tires and does some window shopping, they may or may not come through bariatric surgery, but if someone is sent by their primary physician, they're much more likely to go through with it. So I think for this lower BMI group, really targeting those groups, as I said, grand rounds, going out and taking that day, and maybe it's not national advocacy, but maybe it's go around and meet physicians, discuss, the new criteria.
Yeah, I'll second that with saying, a lot of times people think that when they start in advocacy, the first step should be to go on one of those Hill trips to DC. I've never been on a Hill trip to DC. I want to, but I had so much work to do in Georgia that I was like, I can't go to DC yet. We're 20 years behind the rest of the country. I have been to the Hill in Atlanta numerous times. And I'll also like to start right here at home. So when the ADA and when the papers came out in the Lancet that were so convincing that patients with diabetes should get bariatric surgery with a BMI of 30 and above, the first place I started was in my own hospital, because I'm the person who signs off on that policy as the medical director of our bariatric program. So we immediately made that change. And I mean, it happened super fast. Within literally a month of us proposing it, everyone who works and has our UMR coverage can get surgery with a BMI of 30 and above if they have diabetes. There's very good level 1 evidence for that. Where I'm starting to run into a little bit of barriers is when I talk to people about BMI of 30 with other comorbidities, or anyone with 35 and above, they want level 1 evidence. These insurance medical directors, they're smart. They don't want to just take our opinion that it's great and it's going to work awesome. Where are your trials? So what I think the next step to really getting these guidelines to work is going to be one-offs. So right now, I'll accept any patient with a BMI of 30 and above with diabetes, and any patient with a BMI of 30 and a comorbidity. We welcome them in the doors. We're enrolling them through the program, telling them up front, you are probably going to get denied. There's no question about it. We're going to submit you and your insurance is going to deny you. But at least then I can do a peer-to-peer and have a one-on-one discussion with your medical director, and I might get your case overturned and you might get surgery. This is time consuming. I've told Joe was on a call one time before Georgia got state employee coverage, where I said advocacy is soul crushing. And I fully meant it. And then the next month, Georgia state employees got coverage. And so soul was lifted. I felt rejuvenated, could go again. This is going to be soul crushing for a while. You're going to do a lot of peer-to-peers until the needle moves. But what will also happen is, as these medical directors do all of these peer-to-peers and see the value in it, they're going to go back to their board and real discussions are going to start happening. So that's what I always encourage, is start at home. Go do the grand rounds and present the new data. My group always knows when I do grand rounds, because our referrals go through the roof for a few weeks right after a grand rounds to OBGYN, orthopedic surgery, internal medicine, family medicine, and peds. We have a ton of adolescent referrals right now because I just did peds grand rounds again. And then after your home institution, I really encourage you to take advantage of your state chapter. I cannot undersell enough the value of having a strong state chapter. Joe flattered me so much by saying I led this charge in Georgia. I will tell you, the first time I went to the Hill, I was alone. The second time, a few more people came. And by the end of this, we were pounding the pavement and calling across the state of Georgia, all of our representatives, meeting with the governor, and our state chapter really pushed this home. So you don't have to go to the Hill as your first advocacy trip. I would encourage you to join your state chapter and find a mentor. Find someone who'll go with you and introduce you to people, because that's way more impactful in my mind, is kind of having a tour guide that first time.
That's
good
advice.
Go to the Hill and enjoy some soul crushing about how our government works. I've done a few Hill visits. It's an interesting process. So I encourage everybody to get it. If you have the opportunity, try it.
I have a couple of questions from our illustrious leader, Dr. Dan, who is our Bariatric Surgery Training Committee Chair. And these are great questions. So he says, I've always said 2 to 4 years to recover costs with bariatric surgery. But is that even shorter now, given how expensive our new armamentarium of medications are? Are we actually going to see an increased utilization of bariatric surgery based on that? And the second question is, can you guys comment on access to care for our medical colleagues, the issues of access to care and utilization? Because this isn't just a surgical problem, it's also, an obesity medicine problem.
So I'll start with that one, Joe, because I have a tweet pinned to my account that says if I had a magic pill that you could take to cure your hypertension, diabetes, erectile dysfunction, OSA, like I list a whole laundry list of things that we know metabolic and bariatric surgery can improve, if not put into complete remission or cure, if you like the term cure, for diabetes. And I said, would you take it? And I said, I do have that pill. It's called metabolic and bariatric surgery. And I think that when you look at the cost for a Georgia diabetic, 1 year to take care of a Georgia diabetic on insulin is $16,000. Now you start adding Ozempic on top of that, and holy cow. Surgery is cost effective. When I met with Governor Kemp, and when we got the ball or the needle moved in Georgia, he's a business guy, right? When I first met with his office, the first thing he said, Ryan Luck's the guy's name, he said, this is the best ROI I've ever seen in this office. And it's from a doctor. He's like, I was not expecting this. He's like, what a return on investment. You guys should be marketing this. And I was like, we are. Thank you for listening. And that's ultimately money talks. And if you are going to be long-term on these medications, the medications are great, but it is a continuing thing and it's going to get very expensive. So I absolutely think that is going to have to be discussed.
One thing I always kind of take sometimes out, especially people new into advocacy, I always try to take the tact of, when you get started out, don't get too deep in the weeds with the finances. And I think that's what we always fight at, because as Renee mentioned, we're one of the only specialists who actually gets the push on cost effectiveness. And so my advice is, the problem is we don't know the data as well as the insurance companies know the data. And they put everything in there, and they look like, what we see a lot is, right now, if your BMI is over 40, you can't have a hip replacement or knee replacement. So our referrals from orthopedic surgeons have popped up because, hey, your BMI is 42, I can't operate on you, so go get bariatric surgery. And they go back and they look at that, and 6 months after surgery, they get their knee replaced and they can walk again. That's an expense. They tag that with the cost of bariatric surgery, that kind of nonsense. So I always tell people to stick to just talk about the patients and talk about the outcomes of what we can see and what our data says, right? So when we get rid of diabetes, we're getting rid of blood pressure, we're getting rid of cholesterol and sleep apnea. Let's talk about the patient and the clinical outcomes, because we just don't have the finance data. We just can't grasp it. We just can't calculate it. We just don't have it as well as they have it. They know what it is, right? I mean, they know it's beneficial, but that's not as important. But yeah, so the data that I've seen certainly is far the ROI is far more early than 18 months. It's usually 12 or less. And those calculations are just based on medication costs. China, for example, our current criteria include Asian BMI of 27.5 and type 2 diabetes for bariatric surgery. That's been present in China for a decade, because you talk about a single payer system. They were like, wow, this really pays for itself from every aspect. So they dropped the criteria and actually encourage patients to have metabolic surgery.
I think if we called it something different, I hate the term weight loss surgery. I don't use it ever. This is not about weight loss. It's a wonderful side effect of a metabolic operation that I'm offering you.
So I'm curious if another question, more really a follow-up to what Dr. Jain-Spangler asked for Dr. Dan. We've been pushing really hard, or you guys really have taken the leadership and pushed really hard to improve access to bariatric surgery. Is there a time where we should be collaborating with our Obesity Medicine Association and our medical colleagues to improve the cost of those medications, which I realize is going to take another several years to drop because of patents, but access to them as well for Medicaid, Medicare, locally, regionally, nationally?
Yeah, absolutely. Sorry, I didn't answer that question. Yeah, I think, I'm always the advocate that the, rising tide floats all boats. I think, we have to look at this from a global perspective. And I don't know about you guys, I write a lot of medications for my patients. I have patients that are post-op that I write a lot of medicines for. I think it's a fantastic, right? It's chemotherapy for our surgeries, like colorectal cancer. I look at it as, it's not a bad thing to be on chemotherapy. It's not a bad thing to be on weight loss medications. And I used to be very harsh. When I first started my practice, it was, surgery, you just had surgery. How could you, have any weight recurrence, or how could you need medication? And then when you start realizing about the chronicity of this disease. So I think looking at, and that's why I love comprehensive programs. Some people are right for medicine, some people are right for surgery, and that's okay. I think what we're going to see, though, I think this will overall benefit us, getting more attention to weight loss. And I don't know about you guys, but the new weight loss medications are excellent, but they're not, miracle cures. I see a lot of patients that just doesn't work for. There's a lot of side effects with nausea. This doesn't work for everybody. So I think getting patients in the door is great to be able to have that conversation about weight loss. Let them start on medications if they want to. So I do this all the time for patients. And I think, don't fight against it and say, oh, it's surgery versus medicine. We still work together. I mean, the theme of our ASMBS this year, our annual meeting is, combined therapies. That's the entire theme of this meeting. So I think look at it as a positive thing. I think we're going to see an increase in bariatric surgery utilization after people start coming off this medication, and they are expensive. I don't know if you guys have anybody self-pay their medicine?
Yeah.
$1,200 a month.
Monthly
medicines.
And they're the most upset about the current shortage. That's not going to be improving with Wegovy, and Mounjaro current dosing being a challenge as well. And then what coupons are going to go away in June, July.
So the problem that I have in Georgia, for example, Georgia Medicaid, this is going to be one of the next big local talks that we have on the Hill with Kemp and with our policymakers there. Georgia Medicaid in diabetes will not cover any of these drugs. So I just got a patient with a BMI of 45, newly diagnosed diabetes, and I wanted to put her on Ozempic. That was my plan as first line because she's allergic to metformin. And we got denied. And they said, absolutely not. Do you know what they finally approved as her first line medication? Insulin. So I have a newly diagnosed diabetic with a hemoglobin A1C of like 7.5, who's now on insulin, which we know is a weight positive drug and insanely expensive. I'm just trying to get her through the finish line of my program where I can operate on her. And hopefully she won't need insulin, but that's the kind of thinking that probably frustrates me the most in access. The BMI of 60 with a paraesophageal hernia, diabetes, OSA, hypertension, that an insurance company will allow you to fix the hernia on, but not do a bypass. Those are the ones that used to upset me so much right out of fellowship. I would get so angry in clinic. The key to that anger, young fellows, as you go out, is do what Joe said and harness it. Don't get angry. Just take it and feed your passion and make things better for your patients. Do peer reviews, go get in the game, so to speak. And I'm 100% with Joe. Our access talk, I encourage all of you to come to it in Las Vegas. Joe's going to be talking on the panel, and we have patients. We have a patient, RD, who's going to tell her personal experience of having more than 3 bariatric surgeries and just recently getting approved for Wegovy after advocating for herself, because this isn't just a one and done. And I love Shanika Tori recently said it's neoadjuvant and adjuvant therapy for bariatric patients. We should be using these medications together. We have another person who's going to talk about how to get these weight loss medications approved, because access shouldn't just be access to care for surgery. It should be access to care for all things. So we have people representing the patient, representing medicine, representing surgery on our panel this year. So I would encourage you guys, that's my plug, my shameless plug for my own session at ASMBS. Please come to it, see me and Joe talk, and get really more into the nitty gritty details than we had time to get into today. This will be kind of the copy and paste toolkit of how to go back home and do this.
Insulin was one of the first things that got me really looking at advocacy when I was meeting with our local, when I was in Ohio, medical directors, and they became much more interested in surgery when we started talking about insulin. I just thought insulin was something, it's been around for 100 years. Just went to Costco and bought a bucket of it for $6, and it was cheap and easy. But the newer insulins are ridiculously expensive. Yeah. And so when they start, that's when they start motivating things. And I think there'll be some positive pushback when we have better results in the high BMI patients at essentially a cheaper cost than these new medications. I think that'll be a great benefit to us.
But I see the appeal for the weight loss medications. I can tell you right now, as a physician who does this, If someone said, here's a sleeve, here's some Wegovy or some Manjaro, I would try the Wegovy or Manjaro first. I just would. It's, you know, potentially in the back of your mind, you're always thinking, I could lose, you know, 50 pounds on this. And once I get started, I'm going to be cruising and I'm going to lose all this weight. So I understand the allure. And I think offering both in your practice is key. What we tell referring providers, they say, well, this patient doesn't want to talk about surgery. They want to talk about weight loss. Send them all to me. We do an initial consultation. And if they want our medical weight loss arm, me as the surgeon decides they're appropriate for a medical weight loss arm. My weight loss guy then works with them for 6 months. And after that, if they decide they want surgery, he kicks them right back to me. And now I've got 6 months of physician directed medical weight loss, and we don't have to delay getting them to surgery if it didn't work. So I think we've got a pretty nice team approach right now.
I truly believe that comprehensive approach is the way of the future, right? Being able to work together, because it's a chronic disease, and I think the adjuvant, neoadjuvant comment or comparison makes so much sense. And so we appreciate you guys spending your morning with us and giving us a little bit of help in trying to navigate how to make a comprehensive program when access can be an issue and utilization can be an issue. So really appreciate your time. Thank you again. Dr. Jain-Spangler, take it away.
Thank you, guys. I think your love and your passion and your work in this space has been, for me, really just your role models of the work that we can do and what we can achieve if we put our minds to it. So thank you both so much. Thank you for giving these talks and for being with us. Renee, enjoy your vacation.
I'm not going to lie, for the Pacific Coast talk, I may have a margarita in hand because I'll already be on the beach.
Please do. Please do. You can make it your
it'll
own
be happy hour early. The fellow project combines with ASMBS happy hour. Sorry.
Well, I look forward to seeing all of you in Las Vegas. And until the next month, thank you, everybody.
Thanks for having us.
Thank you, Joe and Renee. I truly enjoyed the talk. This is truly very interesting and very important, especially with what Joe was talking about with the number of sleeve conversions going up because of heartburn and weight gain. My question for you, Joe, is how would you? I know you talked about how on the Access to Care Committee, there's young, passionate ASMBS members who are advocating every single day on behalf of their patients. Do we have in the Access to Care Committee like a way to get the fellows involved beyond joining the committee? Obviously, they can join the committee if they choose to, but what would you suggest for a new fellow, a junior attending who just finished practice, just finished his training or her training, and they're starting their practice, they're trying to build a rapport with their patients, trying to build their practice? What would be the best way for them to get involved? They may not be able to take time off early on, like you're suggesting. Obviously, we all did that at one point, but early on, what would be the best and easiest way for them to get involved?
Yeah, well, thanks so much for having us again, Maher, to answer these questions. So I think the best way to get started with this is start more locally. Our state chapters, depending on where they end up and go to work, are kind of our on the ground network to find out where the issues are and where the problems are. And, some state chapters are very robust and well run and organized, and some are struggling a little bit and everything in between. So I think that's the first place I would start, is to get active in their state chapter. And that's how everyone kind of gets, I think that's how we all got started with, on access to care on the national levels. Renee's working in Georgia, and I started working a lot in Virginia and Ohio. And that's by far the best place to start, is just becoming active in the state organization. And there's always opportunity there for people to get involved.
Yeah. Renee, what about, Joe touched upon, like, do not take no for an answer. And this is something I always tell the fellows when you get denial and your insurance specialist comes to your office and put that file on your desk, do not take no for an answer and try to be a patient advocate. This is how I look at it. Our patients do not have any advocates, and it's upon us as surgeons to become their advocate and do that peer-to-peer and try to get those denials overturned. And every day I have at least 1 or 2 patients where, there's peer-to-peer scheduled, and we try to get those denials overturned. What's your experience with that, and how would you advise fellows to go about doing that?
First, thanks for letting us join again from West Coast time. This has been a really fun day doing this talk, and obviously both mine and Joe's passion within bariatric care and ASMBS. So what I tell everyone is you're going to get denials, especially that first year, because your paperwork may not be quite as tight. You haven't learned all the insurance gains yet. Just be patient. And what I always would encourage you to do is be very polite when they get on the phone, and also ask them why they denied, and then provide education. I would say 99.9% of the time, these peer reviews take me less than 10 minutes. They are super fast. And sometimes it's coming from just a place of not being educated. They'll say, oh, well, we saw in here that, I don't know, it'll be something obscure, like they don't have a BMI of 40, but they have a BMI of 35 with diabetes and hypertension. Maybe just need to update their knowledge of the guidelines, or maybe they just didn't look completely through the packet. Sometimes I think these denials are just a game. I think they are just blanket denying people to see if you will challenge them. And that honestly has been my experience the past few months. I know we all probably saw on Twitter and social media world where Cigna was taking a little bit of heat for the just thousands upon thousands of denials where they didn't even have to open the packet. I don't think that happens as much in surgery, but I think it probably does sometimes. So I always ask why they got denied, and then I take the minute to educate. And I have lost maybe 2 peer reviews in the past 10 years. They almost all get overturned. My patient gets surgery. I think they're just seeing if we'll do it. And I think that's where we'll really lose this battle, is if you as a physician don't do a peer-to-peer. Right. Trust me, set up the time, take the 5 to 10 minutes, you'll win almost every time.
Yeah, I agree with you. That's been my experience as well, Renee. If you make the effort and take the time to actually pick up the phone and talk to the medical director and try to explain to them the setup that we have in place, the comprehensive nature of our practices now as bariatric surgeons, and what we're trying to do, I've had very good success rate, just like you. I remember maybe 1 or 2 that I wasn't able to overturn because the medical director said, I agree with you. I don't have any problem with what you're doing, but the policy is a policy. But they're usually pretty open-minded and they're willing to work with you. The other thing I would add to what you said, Renee, is that in my experience, doing an extensive pre-op workup does help a lot. Obviously we're in an academic center. Everybody gets like pre-op endoscopy and upper GI and manometry and Bravo test. And in my experience, those tests do help quite a bit. I can tell you an example of a patient earlier today where she had no esophagitis on upper endoscopy. Upper GI did not show any reflux except for a small hernia. But when we did the Bravo, her Demeester score was in the 50s. So when I talked to the medical director, he said, I denied that case because there was no reflux on the upper GI. Your endoscopy did not show any esophagitis, but I wasn't aware of that Bravo, and I'm not going to argue with that Demeester score. So she got overturned. So do your homework, do an extensive pre-op workup to gather some data to argue your case. Sometimes I feel like I'm a lawyer, but you have to be. And I
so
know
Maher, I want to jump in here because I think that's so true. So actually, first of all, thank you again to both of you guys, especially for coming back for the afternoon session. I thought the talks were really instructive. But I would also echo some of your comments. I mean, in my experience, I find that a lot of the times you're talking with another physician who just is not aware of the updates, especially with the new 2022 guidelines, and just talking with them, reasonably explaining to them how these patients are going to benefit, I think really makes a huge difference. I do want to ask you guys a question. So Dr. Northup went through some of the different insurance companies, and I thought that was really helpful. In my personal practice, we have a financial counselor here who goes through and does all of that. We screen all of our patients when they come in. So for the fellows who are going out into private practice or even into an academic practice and they may not have a specialist who can pull all of that information for them, can you walk the fellows through like how they can get this to find out exactly how patients could qualify for surgery?
Yeah, so hopefully they'll have someone, if they're joining a practice or starting a practice, they will have some source that they can use to get pre-approvals and evaluate their insurance, because it's a daunting task. I remember when I started the program when I went to Ohio, we had no right. You start with a skeleton crew, and my coordinator and she did almost all the work. Got our first couple surgeries approved, and it was an exhausting process, and it was really 50 pages being faxed, everything being scrutinized. It was very challenging. So hopefully have some resource. One thing, not to be company specific, but Ethicon Johnson & Johnson actually has a website. You can actually search an insurance company and you can pull up the plans directly. I find that to be a very valuable resource for community coordinators. But again, it's very useful for us to use it. If you go to the Obesity Action Coalition website, and you go to the advocacy resources at the bottom of that first page there, and you can go on and put in your insurance plan, and they have it updated every 6 months, and they can go in and find all the criteria. So that really will, again, if they start out a brand new practice on their own with limited resources, that's a fantastic page to use so we can search insurance companies.
Yeah, so I'll say, if you're going to go out on your own and try to do this, I'm with Joe. This can be exhausting to do this, and you're going to spend more of your time verifying insurance and operating if you try to build a very busy practice. Many patient tracking softwares, and there are many out there, I don't care which one you get, but a lot of them actually have a benefit that you can purchase where someone will do it for you. They call the insurance, they record the phone call, they verify their insurance up front. We take advantage of this. It's not a very expensive annual fee. And then the benefit of that is when I see this patient in clinic, my program coordinator has printed out like the page of their insurance that was faxed over to us that has their bariatric benefits listed. It's on the front page of a manila folder, and I have that on every single patient. It lets me know exactly what their policy is. It lets me know if they're 3 months, 6 months, 12 visits, whatever that may be. And I can have that conversation with the patient up front. So I'm a little spoiled because when I walk into a room, I have that handed to me in a folder. But we didn't always have that. When I started this, it was frustrating. And now we have that process, and I have a checklist that I also submit in the same folder to insurance companies when we try to get them pre-authorized for surgery. And that checklist has everything on it that the medical director is going to look for. And it's got a big check with my initials by it and the page number in the folder to turn to. So I've almost tried to make it easy for them not to deny my cases. And it seems to be working because we have a really high first-time acceptance rate.
I'll say one thing about medical directors. We were talking before. Sadly, for most medical directors, they actually get a financial bonus based on percentage of denials. That's kind of an unknown secret that they have. So that's why they're somewhat motivated to deny surgery. Usually if you talk to them in person, that they give in. But another thing, talking about practice building, Renee kind of brought up is, my job I had previously where I was an employed physician, like, again, a 5-hospital health system with the business office downtown, and every surgeon, GYN, general surgeon, bariatric, whatever, they submitted to an office downtown. You submitted your surgery, they got a pre-approval for you and sent it back. So we started out that way. And then once we got to a certain volume, we dominated somebody's time. So they just reassigned, they gave us one person, they put them in our office. So we started out with, the sharing one like everybody else did. But then once we got to a certain volume and we're doing so much work, we got a full FTE to come be in our office, 5 days a week. So you start out somewhere, and where you start out and where you end up are always two different things.
Joe, there's a question in the chat box. Someone is asking about South Carolina Blue Cross Blue Shield state insurance. Do they cover bariatric surgery or not?
They do not.
Yeah.
They have
over though.
Not that I've been aware of, and I talked to Shaina and Scott like 2 weeks ago. So unless that's happened in the past 2 weeks, they have not flipped. And I have a feeling both of them would have called me singing loudly and jubilantly if they had won that battle. So Montana flipped on the map. The three to me are the three that as of 2 weeks ago, Joe, were still left. South Carolina, Idaho, and Utah, I think were the three maybe that were still on that map. But no, South Carolina is right across the river, and I have not had any luck in this past year. And like I said, I just talked to Shaina, and he didn't say any different. I would assume Shaina would probably know.
Okay, what about Joe? Maybe you can, or Renee, maybe you can talk about Obamacare, Affordable Care Act. Left it up to the state to decide whether Obamacare will extend that benefit to the patients. We're one of the unlucky states, Pennsylvania. The other states, Jersey and New York, it's actually covered. So now we go across states, and some of those patients are being done in New Jersey, in our center in New Jersey. But where do we stand on that? Maybe you can give us like an update, Joe.
So how this kind of started was they kind of went through and they have the Affordable Care Act. They listed 10 essential health benefits, and I will go through all everything from psychiatric care to basic health care, trauma, whatever. And, we had hoped there's a chronic disease state condition. We had hoped obesity care would be under that category. However, it was not. So the states have a choice of doing the national plan or their individual plan. And the states, it's about, I think it's like 60-40, maybe, Renee, like 60% on the national plan, about 40% did their own thing. And anyone on the national plan does not have bariatric surgery coverage. Now, that being said, some of the worst coverage that I've seen are the state plans that use the essential health benefits and, have some kind of bariatric care. Some of them are good and some of them are, again, $8,000 deductibles, 12-month diets. They're really poor plans. So it all comes down to money. When you go to these businesses, like I talked about, they want the minimum, the cheapest thing they can get that covers those 10 essential health benefits that must be in the plan. So if it's not required to be in the plan, they don't have to cover it. So they get the basic stuff they have to have in the cheapest price, and that's how most insurance goes. We tried to actually get a meeting with HHS to list bariatric coverage, obesity management as one of the essential health benefits to put on that chronic condition. And I think it changes every presidency also. So in the last administration, I think we got on the list and we were 1,470 something to meet in front of HHS, which means we never got to meet with HHS. So kind of our ultimate goal is to get bariatric and obesity management as an essential health benefit, but I think that's a long haul.
And I was hoping this year that we would maybe gain some traction since they just changed some of the federal coverage. So, the federal coverage now is great, even with anti-obesity medications. So I'm hoping that maybe we can use that as a little bit of leverage on the Hill. And, we've been trying to get TROA passed through for, I think, 10 years, Joe? It's 10 years at least. So, I mean, we're there, we're fighting every day for it. But yeah, I included those as on the heat maps when I went over my discussion, because I was shocked. I thought it would be better because it's the essential health benefit plan. And I would consider in 2023 obesity to be an essential, disease process to cover, but it's not.
And TROA, for those you don't know, is there's Treat and Reduce Obesity Act, which covers mostly dietitian visits, non-physician visits to manage weight issues. And I hate to say this, I encourage everyone to go. Start with your local legislatures, but do Hill visits, do national meetings with your representatives. It's very interesting to see how this process works, and I will say it's very expensive to move a bill along. That's where we struggle a little bit.
I obviously, talking about the TROA Act, I obviously, like all the other surgeons, support the TROA Act. I think just for the fellows to know, the counter argument is that there's a huge price tag behind TROA, right? So if you open that to Medicare patients, you're talking about billions of dollars. And the counter argument is that we don't have enough data on the efficacy of those drugs in Medicare patients, just because most of those trials were done in patients less than 65. And we don't know the implications, long-term implications of morbid obesity in patients who are more than 65. So these are some of the counter arguments. I don't know what you guys think about those arguments.
You're 100% correct. Any of these bills try to go.
They need to be addressed. As surgeons, ASMBS Obesity Care Coalition, we need to take those counter arguments into account and get the data and present the data.
Yeah, no, you're 100% correct. So any of these bills that cost anything, go to the CBO, the Congressional Budget Office, and they do it's actually hard to get a bill analyzed by them. So we actually, so you get that is a big thing, but they just look at the direct cost of this. There's no ROI, there's no offsetting of medications. So they just, like you said, they calculate what this is going to cost, and it's big numbers. It's just big numbers. And so, in this current, I don't say current, for 20 years of, financial struggle with the government, it's just a hard thing to do. It doesn't create a social issue for them or an embarrassing issue to them that costs money. It's hard to move that needle.
Yeah, because
the other problem.
Go ahead, Renee. Sorry.
The other problem that we have, I know, Joe, me and you and Mickey have had conversations about this before too. When you look at even the new guidelines, the level 1 evidence is not as strong as it needs to be in some of these categories. And it's because we tend to do a lot of retrospective studies when what we need to focus on as a society right now, I think, is some prospective studies and really collect level 1 data, because these medical directors, these insurance companies, they're smart enough to ask for that. And when we have it, like we do with diabetes, that's when they start to listen and move the needle. It's time consuming. And sometimes with the money and the financial stuff they want, it can be hard. But I think having level 1 evidence, prospectively looking at these things. And then also, Mickey said this one time, and it really resonated with me. He was like, can we please stop saying at the end of everything we write as clinicians, we believe further studies need to be done to validate these findings. It's like we leave a door open and say, please dispute everything this paper just said. We all know it's true. Stop writing it in the end of every conclusion that you write. And that resonated. I quit writing it. I'm not putting it on my abstracts or papers anymore.
Well, I want to ask you guys a question that might be a little controversial then. So do you think now with the introduction of these more effective weight loss medications, if we were to do these studies, do you think that's going to limit or access or I guess utilization, to use your word, Dr. Hilton, of bariatric surgery? Like, do you think that we are at risk now?
I think I believe in the rising tide floats all boats kind of attitude toward this. I think I think we're seeing a dip right now a little bit in surgery. I think, Renee mentioned earlier today, she's like, if you have an option between taking a pill versus having an operation, you're going to at least try the pill first for many people. And that's not unreasonable to suggest that. But I don't know about you guys, but I think the reality of these medications, I write a lot of prescriptions for medications on just in general and, for my post-operative patients. They're not the miracle drugs that they kind of tout. So I think what this will do, I think it's going to get people in the door. They're going to try these medicines for a few months. It'll work for some people. It won't work for some people. There'll be significant side effects for some patients, and they will then start looking to surgery. And I think we talked about earlier, the comprehensive programs are so important. I always look at, I love to have in my office where my post-op patients are out there sitting next to the medical weight loss patients. And while we have great medical weight loss programs in the past, if your BMI is 50, it's going to be hard to have an impact on your health with just medication, regardless of the medicine. So to somebody that had a surgery, they're going to maybe have a conversation that's going to make a difference. So I think the medicines are really a good thing for us. And I think in the long term, it'll get more focused on obesity care. And I'll be honest, I don't know if you guys have anybody taking these medicines and paying out of pocket about $1,200 a month. We're going to start looking pretty cheap pretty quickly.
Yeah. I think the other thing that I'm telling people right now is, I heard Shaina say neoadjuvant therapy. I think the way we need to be thinking about these medications is as our neoadjuvant and adjuvant therapy, the same way that a cancer doctor thinks about chemo and radiation. Obesity is a chronic disease. I think using every possible means to fight it, whether it be, before surgery and then maintenance after surgery. That's how I've started to think of OAMs as my neoadjuvant and adjuvant therapy. And for me, I think when you embrace that as a surgeon, and I know that Dr. LeMasters, her whole focus for this meeting this year, her and the program, directors were talking about everything, working together, using everything at our disposal to fight obesity. And I think that's how I'm viewing the future of these medications is how can I use them with surgery to get my patients the best results?
Excellent. So I think we could probably continue the discussion for a longer period of time, but we're already over time. So again, I just want to thank both of you guys, Dr. Northup, Dr. Hilton, and my co-moderator, Dr. Chaar, for joining us today. And we will look forward to seeing you guys again next month. Thank you, everyone.
Have a good
Thanks,
weekend,
everyone.
Thanks.